is a video. Multiple sclerosis over 1 year in serial MRIs, and what you're going to see as it runs through this little loop is inflammatory lesions coming and going in the central nervous system, and they almost look like flash bulbs as they go off, and what they leave behind is little scars like this. And so that young woman that we saw her MRI earlier, she had very many of these. So number over time, sorry, try one more time, let you see that. Okay, a number over time of these kind of acute inflammatory lesions that come and go and leave these small glionic scars. Now, of course, the area of the brain that these are occurring in at the time they occur does not work very well. But in the cerebrum, which is what we're looking at here on the MRI, most of those lesions are asymptomatic or minimally symptomatic. And the reason is because there's a very large piece of brain tissue, and although are often a couple centimeters across. They don't cause so much dysfunction as to be noticeable. The ones down in the brainstem and spinal cord are the ones that clinically are more noticeable. Now, this is what happens over many years. This is a different way to show the brain tissue, and what you're seeing is the dilation of the ventricles and the sulci over time as a consequence of this continual inflammatory inflammation causing microscopic injury throughout the brain. You're seeing the from year to year. This is what's really disabling in MS. This is what produces the cognitive dysfunction that's permanent and many of the permanent disabling neurologic symptoms. We used to think that people had MS when they were disabled. In fact, we didn't want to give them a neurologist. The doctors I trained with, who'd been around and treating MS since the 60s, they didn't want to tell people they had MS till they had trouble walking. Well, there wasn't anything to do for it. So people with MS, they were all in wheelchairs. But actually MS is the clinical diagnosis that means they have recurrent or chronic inflammatory disease in the nervous system without some other explanation. Most of these people work full time, but 90% of them are going to go on to serious disability. Now, why do we want to diagnose MS early? Well, all of you have seen patients who don't have a diagnosis for any kind of problem. They absorb a lot of resources. They go to the doctor a lot. It just social schedules if they have an undiagnosed illness. There are safe and effective treatments now available for MS. One important thing is if somebody has a number of complaints, is to avoid alternative misdiagnoses and sometimes even surgical treatments, which may not be necessary. And what I want to talk about today is that treatment's really much more beneficial when started earlier because it prevents the progression of disability and prevents the brain atrophy. And towards that end, in this audience, I want to give you as much information. Understanding what MS is and how it shows up in a fashion that you're going to see it. Now, everybody's taught in medical school MS is dissemination of these lesions in space and time. For practical purposes, we're talking about lesions that we notice clinically in the spinal cord, brainstem, optic nerve, cerebrum. And we have criteria that are based on this. They're called clinically definite criteria. There's laboratory definite criteria that are based on the spinal fluid abnormality being present. There's MRI criteria that have been developed by prospective. And of course, we assume that we don't have a better explanation for the dysfunction. Now, there are typical ways and there are less typical ways that MS shows up. The usual appearance of a relapse or exacerbation, as it's called, is that it has an onset over days or weeks, a well-defined neurological lesion. We usually describe these clinically as partial transverse myelitis, optic neuritis, or brainstem syndrome, because it's usually going to show up as in one of these fashions, although very large lesions may show up in the cerebrum. People can also have multiple. A single time as part of a relapse. Or they can have a very diffuse kind of problem where there's a lot of things wrong, or maybe a cognitive problem that on further examination looks to be due to quite a few lesions. Less commonly, someone will present with a problem that's not obviously neurological. It may be transient dysfunction like a stroke. It may be more like a psychiatric illness, like someone with hypochondriasis. Or just simply a fatigue complaint or something that would sound like fibromyalgia at the outset. There are a lot of people, and neurologists are among them, that think that people with MS don't really have problems because they look pretty normal. But the average duration of symptoms prior to a diagnosis of MS is 4 years. And if you can imagine going 6 or 8 years being an intelligent person and knowing that there's something wrong with you and not having a clear answer, the kind of frustration that engenders in your life. You can get an idea of what many people go through before they ever get a diagnosis. But we do require that. Some kind of objective deficits or objective laboratory or imaging abnormalities to establish a diagnosis. There are many, many opinions about MS which have turned out to be wrong. And one of these was that MS always begins under age 30, which is actually, is published in a very standard textbook of multiple sclerosis until recently. And actually, a majority of the illness begins after age 30, although there is really no rule about when these kind of illnesses start, because they're defined pathology. There's only things that are statistical, and while most people are adults or young adults when they have the illness, it can really be quite variable when the onset is. We used to tell people MS is a rare disease, that they were unlikely to get it. In fact, a lot of insurance policies are still written that way, assuming that it is a rare disease. But in fact, it's not uncommon. In Minnesota in 1990, almost 1% of women over 50 have MS. And in some British provinces, and the prevalence has been increasing continually, and we presume that's ascertainment due to more training and neurologists are available and more MRI scans. We used to think that MS was a woman's disease and was rare among men. Charcot, if you don't know who he is the father of modern neurology, who was in Paris, and he was the first one to clinically really describe in a characteristic criteria of what although other people had noticed it. But we know a third of it